you are in listen-only mode, and so you will only be able to see your name. If you have questions, please send them to the presenter and myself by using the chat panel. The button to open the panel is located on the upper right side of your monitor. Again, please use the chat panel rather than the Q&A panel to send any questions you may have as you think of them. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now. I apologize. I don't think we were on our slide, so let me start that again. Our audio is broadcast through the internet to your computer, so if you experience poor computer audio, please try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation is actually the materials are available on our site now, and I did post the link in the chat panel if you want to print those out, but the recording will be available on our website within 30 business days. One helpful hint is the archived video displays what looks like an error message, but it's only a delay buffer, so you can just ignore it, hit play, and enjoy. To access the recording and PowerPoint, go to www.fada.org in the Resource Center Training Library, and again, that will be available within 30 business days. We try to have it posted sooner, so that's the directions to get to our training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close on Friday, December 11th at midnight. 1 to 2 continuing education credits are available for participating in today's webinar. For persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. Please note that WebEx monitors your arrival and departure of attendees, and it provides a report upon completion of the event. So it's important that you attend the entire event through audio and video. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to give partial credit. And with that being said, I'd like to introduce our presenter today, Gabriela Zapata-Alma. She is the Director of Policy and Practice for Domestic Violence and Substance Use at the National Center for Domestic Violence, Trauma, and Mental Health, as well as faculty at the University of Chicago. Gabriela brings 15 years of experience working with people living with HIV/AIDS impacted by housing instability, substance use disorders, and mental health conditions, as well as survivors of domestic violence and other trauma, providing direct services, training, advocacy, and consultation, and leading programs using a trauma-informed approach, motivational interviewing, harm reduction, general responsive care, housing first, and third wave behavioral interventions. Gabriela has provided technical assistance through SAMHSA and other national leaders in best practices. Gabriela has been recognized with numerous awards, including Health and Medicine Policy Research Group's 2018 Health Award and the Illinois Association of Addiction Professionals chapter of NADAAC's 2017 Rising Star Award. Gabriela has provided training and technical assistance related to serving marginalized communities impacted by trauma and other detriment of health locally, nationally, and internationally. And Gabriela has shared with us this morning that the temperature in Chicago is in the 30s, which is the same as in North Florida. So we're all cold this morning. And with that being said, Gabriela, we'd like to welcome you, and you can start whenever you're ready.
Thank you so much, Karina. Thank you so much for that warm welcome. And thank you, FADA, as well as the Florida Department of Children and Families for having me today. I'm so happy to be here with y'all and talk about evidence-based practice. And evidence-based practice is obviously a huge topic. So for today, we'll be focusing on selecting evidence-based practices and Fidelity resources. So here is my contact information. If at any point, it's helpful to reach out to me, please feel free to reach out to me. I'm more than happy to offer additional resources, help troubleshoot any situations, or just offer some kind of general technical assistance. So always feel free to reach out. And a little bit about the National Center on Domestic Violence, Trauma, and Mental Health. We're a special issue resource center dedicated to addressing the intersection of domestic violence, trauma, substance use, and mental health. So we have an array of training and technical assistance services and resources. We conduct research and evaluation, as well as policy development and analysis. And we also offer some different public awareness tools and have different kinds of public awareness campaigns to help raise just the awareness of these intersections. And then here's my government disclaimer that the things I say don't necessarily reflect the official positions or policies of the U.S. Department of Health and Human Services. So at the center, our work is rooted within this integrated framework so that everything we do is coming from a place that honors survivor-defined approaches, that survivors are the experts on their own experience, that people know what they need, what may be helpful or not helpful, and what they feel ready for and what is safe and possible at this time. That everything is based within physical and emotional safety, and that isn't something that we can define for somebody, that we really have to work with each person to understand what helps them to feel safe. And what their experience of safety is. That our approaches are relational, that they're really based in relationship and connection, and of course that this is what makes it possible to foster hope and resilience. And so with this at our core, we then are able to strive for trauma-informed approaches that are based in human rights and social justice. Approaches that have an awareness of and responsiveness to cultural, historical, and community context, and come from a place of advocacy and empowerment. So our plan for today, or at least the next couple hours, is as a result of participating in this session, attendees will be able to describe the steps involved in using evidence-based practice, use bottom-up and top-down approaches to measuring fidelity, and will be able to articulate a framework for evidence-informed adaptation of evidence-based practice. So first, we're going to start out with definitions and steps. So if the objectives that I just shared didn't mean a whole lot to you, if it was like, okay, what does any of that mean? Well, that's okay, not to worry. You're still in the right place. So we're going to start out first by just, defining and kind of explaining and unpacking what do we even mean when we say evidence-based practice. It's become somewhat of a buzzword, right? And so it can be easy to have heard this word a lot, but not actually really have heard something that was maybe meaningful, that felt meaningful about it. And so I'll start by saying that evidence-based practice is an orientation to practice that values evidence, meaning research evidence, as well as just evidence that we measure throughout treatment services, as a resource for clinical decision-making. So I'll kind of start us there and then move into more detail. First, looking at evidence-based practice as a noun or as a product. So here, we're talking about an evidence, what often is referred to as an evidence-based intervention, an evidence-based practices or skill set, or an empirically supported treatment. There's a lot of different kind of words that mean slightly different things that are talking about evidence-based practice as a noun or as a product. So here, this is a practice or a skill set that has been established as being effective through scientific research. And of course, this has to be according to a set of explicit criteria. So, what exactly is it effective for? So, for example, there are some relational evidence-based interventions used in substance use disorder treatment that have been found effective for improving relational functioning, but not necessarily effective for reducing either the volume of alcohol use or the numbers of days spent drinking. And so in that case, we might consider that to be evidence-supported, not just for substance use disorder as a standalone, but as an add-on to substance use disorder to help support people's relational functioning, since we know that relationships play a large role in recovery. So that's just kind of one example in terms of what we're talking about when we say that something is effective according to explicit criteria, like even just what is it even effective for? What are we talking about, right? And so so with that in mind, a lot of times people think of evidence-based practice, and I think of it only as a noun or a product, that it is, that they think that we're only talking about, a manual or kind of a set standard, like a group curriculum, right? And so we're going to start by first sharing what evidence-based interventions are used in your setting before we get into the other way that we practice evidence-based practice, which is as a verb or a process. So before we get into the verb or process, I want to hear from folks, if you can enter in the chat, thinking about evidence-based practice as a noun or as a product. What are some evidence-based interventions that you're using in your practice or are used in your setting? And while you think about that and you enter that in the chat, I want to explain this graphic I have on this slide. And this here is the hierarchy of evidence, of research evidence, where, we can have a randomized controlled trial that had an outcome, right? But if that outcome only happened at one time in that one study, then it hasn't been generalized, right? We don't know if it might have been potentially kind of like a one-off. So when we have multiple studies that then are systematically reviewed, or where the data and the numbers are kind of re-crunched and reanalyzed, and then at that point, meta-analysis is done. That's much stronger evidence because we're seeing the benefit of the replication of results, whether the results get repeated or maybe if the results are more mixed, and then we can see, okay, that had a positive outcome in this one study, but we didn't see that in these other studies. So you can see how having multiple studies and analyzing those and reviewing those can yield much stronger evidence than just one study. At the same time, there are some conditions and situations that can be very difficult to study, where there might even be ethical concerns in studying them. Like, for example, when we conduct studies with people who are pregnant, there can be a lot of ethical concerns that are raised, right? And we need to be very careful in our research. And so in some cases, when something is either, there are barriers to rigorous study because of potentially, potential harm and needing to have ethical research practices, or potentially there's a problem that's been newly defined, that it's so new that there just hasn't been much research done yet. Then at that point, we may rely more on things like case studies that are much more kind of local kinds of research, where we know what may have, what something may have looked like in the case of a handful of people or one person, right? Or we can also have expert consensus-based guidelines, which is a group of people who are considered to be at the forefront, kind of the cutting edge of the field, are surveyed or come together and talk about best practices, and then a report is generated based on what they can all agree on, so what the consensus is about what's best practices based on their practice experience, their practice wisdom. So that's another way of collecting and generating kind of evidence in the absence of rigorous research evidence. So, and this is where we get the hierarchy, right, of kind of the decreasing bias. So now I'm going to go to the chat and see what people have entered in terms of what are some of the things that they're using either themselves or in their practice settings. And here I see one that's called T4C. And I am actually not familiar with that acronym. So if somebody could, if Kim, if you could enter what that stands for, that would be great. Thank you. I'm also seeing motivational interviewing as well as the combined motivational enhancement therapy with cognitive behavioral therapy. Yes, very evidence-based and has been tested with a variety of individuals across races and ethnicities and different kinds of substances and situations. So it's always great when we see that something has been really well tested across diverse experiences. Matrix and seeking safety, living in balance, cognitive behavioral therapy, and trauma-focused cognitive behavioral therapy, dialectical behavioral therapy, let's see, trauma-informed interviewing, yes, brief solution-focused therapy, thinking for a change. Thank you, Chuck. Yes, I remember that one. That is, and Kim, thank you. Yes, Thinking for a Change, developed by the National Institute of Corrections. I remember that one now. Just hadn't seen the acronym. Thanks so much for putting that in the chat. And feel free to continue entering in the chat as we move forward. So here is a list of examples of evidence-based interventions. Specifically, most of these are specific to substance use, but I made sure to include some that are not specific to substance use as well, since I know that many times we have people who are family advocates and, work in allied fields in these sessions. So if there are any of these that, you're curious about, or you're wondering about, okay, who is the target population, or in what settings is that used, feel free to enter that as a question, and I'll make sure to talk more about it once we get to our question and answer portion of today. Now, something I want to mention, of course, is that evidence alone is never enough to make a clinical decision. So that in evidence-based practice, we are valuing evidence in our clinical decision-making, but it's never the only thing that we're considering in our decision-making. And that, of course, evidence-based practice must be collaborative. And I see here in the chat, Candace also wrote in 12-step facilitation and SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. Yes, these are both very evidence-based, and SBIRT has actually been found to have the highest return, the third highest return on investment when it comes to health after childhood immunizations and tobacco cessation. So SBIRT is a really, really easy to implement, low-cost intervention that can have really great, really positive outcomes on health. So that's evidence-based practice as of now. Now we're going to move into evidence-based practice as a verb or process. And so here, I just mentioned that clinical evidence, research evidence, is never the only thing that we are considering in clinical decision-making. And so our approach needs to be truly collaborative with the people impacted, the people in our services, whether someone is accessing, from the micro level of someone who is accessing our service to the community level. So really that communities who are impacted by the problem that we're hoping to help people with, or, the communities that we are part of are really centered in decision-making and in crafting programs and what will be helpful. So really taking the approach of nothing about us without us. So in evidence-based practice as a verb or process, we consider client conditions, needs, circumstances, preferences, and values. We also consider best available evidence about intervention options, including potential risks as well as benefit. And this is something that we openly talk about with people in our services, and that's an important part of informed consent. And that people then can be aware of what some of the research has to offer, what are some of the potential risks and benefits, as then they are able to then state what are their preferences, and that, of course, we can't necessarily be experts in every single kind of intervention, but that we may be linking people to services if they do have a preference for a specific intervention that we are not able to offer at that time. And then, of course, keeping in mind contextual resources and constraints on intervention options. And so this means basically that it's reality-based, that, again, we're not able to necessarily become proficient in every single intervention, or every single intervention may not be available within our setting. So a housing intervention may not be available in our outpatient treatment setting. But we can certainly talk with folks and help connect them to those resources when and if those are resources that they need and they want. The steps in evidence-based practice. Here, we really want to think about what are our steps in information gathering and then synthesizing that information to then come to clinical decision making. So our steps from kind of the beginning all along the treatment journey. So first, just initial contact and assessment. So getting to know the people who are the person or the people who are coming in for services. And on a kind of program level, this might include a community needs assessment, or on a macro level, a systems level, this could include a community needs assessment or an environmental scan. And on a micro level, on a kind of client level, this would be more specific to like our intake and our diagnostic assessment processes. From there, formulating a practice question. So a practice question includes things like, for helping to reduce symptoms of trauma and substance use disorder for women who have experienced, let's say childhood abuse. What are the best interventions? What are the most effective interventions? So, something along those lines. So that's more of what's considered a background question, kind of what's the best intervention for this experience, for this goal, for this group of people. Of what's considered a foreground question might be something more along the lines of, what is more effective for people in early stages of problem drinking, cognitive behavioral therapy or motivational enhancement therapy combined with cognitive behavioral therapy. That's considered more of a foreground question because it's more specific in terms of, is it, this intervention more effective than that intervention? But that said, if that sounds like way too in the weeds and way too much information, for the purposes of our time together, that's not something that you have to necessarily memorize. But just know that as you collect information, you want to be thinking about, what kind of questions will help guide my search for the best available evidence. And so from there, we want to go into locating best available evidence. And I will describe bottom-up versus top-down approaches. From there, as we locate the best available evidence, we want to analyze the validity and the usefulness of that available evidence. So there can be a lot of evidence out there that has conflicting results. And part of that is because, maybe more research is needed, or maybe there's inconclusive, right? The results are just inconclusive. Another reason is because there can be a lot of bias in research, or research that just wasn't as using methods that were as valid or reliable. They weren't as controlled. And so there, we want to be able to, consume research. We want to be able to look at research and be able to apply our critical thinking skills. Was the research well done? What bias exists in the research? And then from there, is the research actually useful for my setting, for my population, for the goals of my client or clients? And so there, what I'm describing is practical significance. Is it something that actually relates to the values and the preferences and the needs of the person or the people that are coming to us for services? And so I realize that for folks who may be newer to evidence-based practice, I may be describing things that sound really out of reach, like how do I even begin to, critically appraise research? And so there's a lot of resources out there around even worksheets that you can kind of fill out as you read a research article to critically appraise it. And I also know that FADA has had past webinars that are in their recorded library on evidence-based practice, so that would also be a resource. From there, you want to then collaboratively select interventions with the person in services. So really sharing with them what you found and talking through what they think would be the most useful, what they think really would be responsive to their situation, what their preferences are. And so much of this also takes into account and is informed by culture. From there, applying the practice, and then, of course, evaluation. Evaluating both individual outcomes, so is this intervention working the way that we would hope it would work? Is the person being able to make meaningful gains towards their goals? And if not, do we need to adjust? Or do we need to abandon this practice, right? Is this practice just not a well-fitting practice, not well-suited for the person in their situation? Or do we need to adjust it, potentially even culturally adapt it? And then we also want to measure our own process. And this is measurement applied to the program and the person providing the intervention, implementing the intervention. Because if I'm the counselor and I'm not implementing this intervention the way that it was designed and tested, so in other words, with a high level of fidelity, then the person may not be experiencing the outcomes that we would hope for, but it's not necessarily because it's the wrong intervention for them or because we need to adapt the intervention. It may be because they're not actually receiving the intervention the way that it was designed. Because I, as the practitioner, need some help, potentially some coaching to increase, or some different kinds of resources to increase my fidelity. And I'll talk more about kind of measuring that. So here I promised to tell you about bottom-up versus top-down approaches to locating evidence-based practices. So a bottom-up approach is forming that practice question and then conducting that electronic search to locate the best available evidence. So in the bottom up, we have our contact with the client, assessing their problems, needs, and goals, describing the goals to be achieved and the problems to be resolved. And then from there, defining a course of action and identifying the information that we need to both understand the problem as well as achieve the goals, help them achieve their goals. We take that information and we turn it into a practice question. And a practice question needs to be an answerable question. So for example, adolescent girls and depression. That is not a question, right? I could certainly search adolescent girls and depression, and I'm going to get a whole lot of information, including theoretical information that isn't necessarily research or evidence-based. I might get some, memoirs. I might also get some research evidence, but it's not. It might be telling me, risk factors or protective factors versus treatment interventions. So I might get a whole lot of different stuff, right? Because adolescent girls and depression is just kind of a general two terms together. It's not an answerable question, right? Versus, what are the risk factors for suicide among adolescent girls who are experiencing depression? That is an answerable question that then will help me locate potentially some different kinds of screening tools or assessment tools to be able to assess risk that can help me if I am working with that population who experiences that problem, right? And I want to maybe have some better tools around assessing risk levels so that I can respond accordingly. And then the top-down approach. So we don't always have to begin from scratch. So in the top-down approach, once we have a sense of the needs, the problems, the goals, the situation, the setting, the values, the preferences, right? Once we get a sense of the landscape in that way, we can go directly to a registry or a clearinghouse of evidence-based interventions and look at what are the evidence-based interventions that a lot of times these registries, these clearinghouses have search functions, so we can define, like population and goal and diagnosis and setting, and then it'll, generate a list. And even many times these registries will provide some analysis of the available research and cite the different research studies and say things like, okay, it has strong evidence when it comes to addressing illicit substance use, but has, moderate evidence when it comes to addressing alcohol use. Sometimes it's even that specific in their analysis of the evidence, which can be very useful. Like there are some different evidence-based interventions for young people that have been found effective with illicit substances other than cannabis, but not effective with cannabis. And so if that young person is coming to us for help with cannabis use disorder or risky cannabis use, then that's something that, would be important for us to know and would be important for us to seek out an intervention that does have some effectiveness, some demonstrated effectiveness with cannabis use disorder and young people. Now, you might be asking yourself, well, Gabriela, why wouldn't I always just use a top-down approach? It seems like it's much simpler, much more streamlined, and guess what? I'm really busy in my day-to-day to be, forming practice questions and conducting electronic searches. Absolutely, I hear you. And so the one thing with using top-down approaches is that we still need to be able to critically assess the accuracy of evidence. That especially when we are kind of going off somebody else's assessment of evidence, there can be even more opportunity for different kinds of bias to show up, research bias. And so we still want to be sure to be able to understand what the evidence is saying, to be able to notice when there's bias. So, for example, if the person who is critically praising the evidence was also the principal investigator in all the research conducted on this intervention, well, that might be then they might have an interest in that their research gets highlighted and is found to be really highly effective. And so we still need to, have our critical thinking hats on as we use top-down approaches. So here are some different resources for different registries that exist. So SAMHSA, the Substance Abuse and Mental Health Services Administration, has a whole evidence-based practice resource center. NIDA, the National Institute on Drug Abuse, also has a research-based guide that lists many evidence-based interventions. The Cochrane Review and the Campbell, the Campbell collaboration also can be very helpful. We at the National Center on Domestic Violence, Trauma, and Mental Health, we have an online repository of trauma interventions for survivors of intimate partner violence. There's also the National Child Traumatic Stress Network, which has a fantastic and really in-depth registry and so many resources specific to working with children and adolescents, and can be very helpful with working with families as well. The Veterans Administration also has a National Center on PTSD that can be exceptionally helpful, and they also have a lot of free applications for smart devices that are kind of companions to evidence-based practice. So that can be really helpful to work with folks who who have access and like using applications as part of their care. And then there's also the California Evidence-Based Clearinghouse for Child Welfare, since I know that many times we do have people who work in family services. Now, something to note here is that top-down evidence-based interventions can sometimes be disseminated through an agency directive. So an agency may say, motivational interviewing is one of our core interventions, and everyone here is going to be, highly trained and highly supported in using motivational interviewing, and our expectation is that people are, able to use motivational interviewing whenever it is appropriate, whenever it is indicated, right? Evidence-based interventions can also be disseminated through government guidelines. So it may come through either, regulatory bodies or through funding that may say, here is a list of evidence-based interventions that we expect you to be using evidence-based interventions, and here's a list to choose from. Or they may also get disseminated through accreditation requirements. So if you're accredited through the Joint Commission or the Council on Accreditation or CARF, there may also be, or another accrediting body, there may also be evidence-based interventions that are required through those accrediting bodies. So in top-down dissemination, training, implementation, and fidelity are always important areas to be really aware of, because the last thing we want is folks thinking they're using motivational interviewing when they're using a lot of techniques that are don't have fidelity to motivational interviewing, that are not motivational interviewing. So, and in these cases, many times clinical directors and supervisors end up needing to fulfill the role of trainer, of coach, and of fidelity monitor. And so for those that are clinical supervisors, that are directors, that are potentially even quality improvement or quality assurance folks in the session today, the fidelity part is going to be especially important. And if there are established fidelity tools for an evidence-based practice, then I highly recommend your organization supporting you in getting some formal training around using those fidelity tools so that you can really have just access to the resources available and really coaching your teams and measuring fidelity to these evidence-based interventions. It can make, as a former director who was many times in the role of trainer, coach, and fidelity monitor, it can make all the difference to have some formal kind of resources and training in facilitating training and coaching and in measuring fidelity. I also want to highlight in Florida-specific evidence-based intervention guidelines and resources. So the Office of Substance Abuse and Mental Health has published evidence-based intervention guidelines, and here is the link to be able to access those. And there are additional resources, registries, and clearinghouses that are recognized by the Office of Substance Abuse and Mental Health in Florida, and I've listed those here. Blueprints for Healthy Youth Development, the Office of Juvenile Justice and Delinquency Prevention Model Programs Guide, Suicide Prevention Resource Center, and Evidence-Based Practices for Substance Use Disorders. And anywhere where you see this blue font that is underlined, that is an active link. And so Karina has put a link to the slides in the chat, and if you go and download the slides, you should be able to go ahead and click right on that to take you to that website. So now we're going to launch our first poll, and I want to hear from y'all. How do you currently use evidence-based practice? So do you use it as a noun or product? Do you use it as a verb or process? So the noun or product meaning things like motivational interviewing or CBT, right? The verb or process meaning what we've just described in terms of locating best available research and synthesizing that with your local kind of contextual factors and client needs and preferences and goals, and then evaluating, both how you're implementing it as well as the outcomes that the people and services are experiencing, and then adjusting your practice based on that. Whether you currently use both, practice both, or neither, or, I'm not really sure. I'm still kind of new to this, and I'm still trying to get the hang of what you're talking about. And we'll give folks another 30 seconds to make their selection. So if you haven't made your selection yet, you still have time. All right, Karina, are we able to share the results? Excellent, thank you. So the majority of responses indicate using both as a noun and a verb. Excellent. That's definitely what we want to aim for. And then those who are using one and not the other, that's great that you've gotten started and that, you're already doing one part of evidence-based practice. That is great, and that means that you have a lot to build on. And for folks who aren't sure or, aren't practicing either way yet, then I'm so glad you're here. You're in the right place. Thanks so much, Karina. And thanks so much, everyone, for your responses. So then moving along, now we're going to start talking about fidelity. So again, fidelity is, making sure, or actually, no, let me pause. I'm going to hit the pause button before I say why, more about fidelity, because I actually want to take a moment and hear from y'all. So why concern ourselves with fidelity? Why even, if I'm doing this thing, I've been trained in seeking safety, I've read the manual, I'm doing it, I know that it has good research for, trauma and substance use and, has good research for women and men and across, racial and ethnic diversity, and has been tested with people who have survived domestic and sexual violence, right? Like I know it is highly evidence-based. Why do I have to concern myself with fidelity? And I'll give folks a moment to answer in the chat. Candace, we need to be concerned because it is easy to drift from the model that has been studied. Yes. Thank you so much, Candace. So, we all will naturally drift, right? That's just kind of part of the ebb and flow of being in clinical services all the time. And we call it drift because we don't notice it's happening. And it can happen little by little. And then if we're not having some ways to really tune into Fidelity, then we might find ourselves really stranded on a desert island somewhere, and we'll be like, how did we get here? How did I drift this far, right? And then Paige wrote, we need to know that it works. Yes, we cannot even begin to answer the question of whether or not an intervention is working for someone if we can't first answer the question of whether we are delivering the intervention. Absolutely. And then Gail wrote, because we live in an ever-changing world and things change, we need to stay on course too. Absolutely. Especially in our field, it's like things are constantly evolving and changing, and the different requirements or regulations can be changing as well. It's working in all of our different fields. Something I'll say is that it's very hard to get bored, right? Things are always changing, and so really that's where it can be, again, so easy to not even notice that we're drifting. And someone mentions it will help us to stay focused. Absolutely. So when I, am having, as a counselor, when I'm thinking about Fidelity, when there is someone coaching me and supporting me on Fidelity, when there are some kind of, objective measures for my Fidelity, then that helps me stay true to the model because we're talking about it, we're thinking about it, I'm being coached on it, and then when I'm in session, all of that is really feeding into my being able to really being able to support my practice. And then Frank wrote, without Fidelity, there is no guarantee that you are delivering the EBP as intended and designed. Therefore, you may not get the intended outcomes and impacts. Absolutely. We cannot assume that we will get the intended outcomes and impacts, and that we cannot assume that we're going to have the same benefits that were found in research if we're not implementing it the way that it was studied in the way that it was designed. Thanks so much, everyone. So just how there are bottom-up versus top-down approaches to locating evidence-based interventions, there's also bottom-up versus top-down approaches to Fidelity. And so bottom-up approaches are going to create a tool based on the core components of the program. And so here, we're going to be really defining what are the core components of a program. And I have a framework that we can use for unpacking some of those core components. The top-down approach is using an existing tool. And many times that tool has been supported by research evidence. Many times the tool itself has been researched. So in top-down approaches, we're using a standard tool. And that tool many times has been not only studied in of itself, but many times may have been the tool that was used when the intervention was being studied in research to make sure that when the intervention was researched, that the practitioners in the research study were practicing with a high level of fidelity. and that they weren't just kind of doing their own thing and having the good outcomes, right? When we're using a standardized tool, that data can be used in supervision and training for ongoing quality improvement. And that can really change the kinds of conversations and the quality of coaching that we're having. Sometimes when I can think back to when using a standardized tool with staff, whereas beforehand trying to kind of just reflect the staff and coach them without the standardized tool, it was, my input was received as being very subjective. As, well, Gabriela, I know that that's your approach, or, I know that, you see it this way, but this is how I practice, motivational interviewing, or this is how I practice, this part of CBT, right? Which is fine. People do need to have their own clinical style, and that there does need to be ownership, and people need to be genuine when they're delivering an evidence-based intervention. It's not a cookie-cutter approach, right? And when I used, with that same staff member, a standardized tool, then it was no longer about what I, quote, thought as much, or, well, Gabriela, that's kind of your subjective or idiosyncratic kind of idea of this, but there was a much deeper engagement because it felt so much more objective for the staff member. And as it felt more objective, then it felt a lot more motivating for the staff member, that they could really much more clearly understand what, how to improve their skills, how to deepen their skills, what they could work on. And it was frankly exciting for a staff member who previously, when receiving feedback, had found feedback very invalidating. So that can be really helpful in just supervision in general. And then program level tools can be used in program development and quality improvement. So there's both tools to measure kind of clinician behaviors, but then also program level components. So now we're going to go into an example so you can have an idea of kind of what this looks like with a top-down Fidelity tool. And we are getting close to our midway break. So after we review some top-down tools, we'll go ahead and take that 5-minute break. It's just going to be a little bit after the midway point. So I wanted to highlight the motivational interviewing treatment integrity tool. And so we know that motivational interviewing has a large evidence base in both effectiveness and implementation science. And so the purposes of this tool is to measure treatment integrity for clinical trials of motivational interviewing. So it was developed and used for in motivational interviewing research. Also as a means for providing structured, formal feedback and coaching to improve practice in non-research settings. And some people have also decided to use this as a component for selection criteria. So selection criteria for both including people in training. So for example, being able to tell whether somebody would benefit from more of an introductory training versus more of an intermediate or potentially advanced training, as well as for hiring. Now, this tool measures both behavior counts as well as global scores, and I'll explain what each of those are. And it only looks at a 20-minute segment of an audio recorded session. So
Gabriela?
Yes. Yes. Can you hear me? Can you hear me? Can you hear me?
It seems that we're having some technical difficulties, so if you want to go ahead and let's take our break now until she can get back on the line. It's 11 o'clock, and if you could be back at 11:05, that would be great. Thank you.
Hi, can you hear me?
Gabriela, I can hear you fine. Do you hear me?
Okay. Yeah, I can hear you.
Okay, I'm trying to get in touch with Karina. If we want to go ahead and take the break now, I'll get in touch with her and we can pick up when we left off in 5 minutes.
Okay, great. Thanks.
Okay, you're welcome.
Okay, can you hear me? You can hear me now? I just can't hear anybody else.
I can hear you.
I hear you too. Did you hear us, Ruth?
No.
Okay, why don't you call on that?
Okay.
All right, we're working through the issue and we'll have it resolved in just a minute or two.
All right, everyone, I think we'll go ahead and start back up now. Okay, so hopefully folks can hear me. So the Mighty only analyzes a 20-minute segment of an audio recorded session. Thanks so much for Paige for putting in the chat. You can hear me. It's good to know. So if there's video available, then you just wouldn't look at the video. You would just only score the audio portion. So I mentioned the global scores and the behavior counts. So the global scores are something that you would listen to in that session and then determine a ranking on this scale from 1 to 5, low to high. The global scores include cultivating change talk, how well somebody softened sustained talk, partnership, and empathy. And as you see on this scale, this is an image, this figure is from the Mighty Manual, that each number on the scale has been anchored. It has been defined. So again, creating more objectivity around it. So in order to really assess somebody's global score of empathy, let's say, we need to be able to differentiate empathy from other characteristics. So empathy is not to be confused with warmth, with acceptance, with genuineness, or with client advocacy. And so, thinking about, for example, empathy versus warmth. A clinician may work very hard to understand the client's perspective, but not be especially warm or friendly while doing so. Or empathy versus acceptance. A clinician may, may fully understand a client's experience, but may not agree with their perspective. Or genuineness versus empathy. A clinician may be fully present and authentic, but not really make any efforts to understand the client's perspective. And client advocacy versus empathy. A clinician may be invested in helping the client or gaining services for them without really any efforts around trying to understand their perspective. So here on this empathy scale, we see on the low end, the clinician gives little or no attention to the client's perspective. And the midway point, the number 3, the clinician is actively trying to understand the client's perspective, but doesn't have a whole lot of success. So they're trying, but they're not really getting the client yet. And then high level of empathy 5 is a clinician shows evidence of deep understanding of the client's point of view, not just for what has been explicitly stated, but what the client means but hasn't said yet. So now the behavior counts. So these are actually, discrete strategies and behaviors that a clinician would use that are part of the skill set or not part of the skill set of motivational interviewing. So, for example, confrontation is not consistent with motivational interviewing. Neither is attempts to persuade. So those two would kind of count against somebody's fidelity in using motivational interviewing. Whereas simple reflections and complex reflections are consistent with motivational interviewing. In motivational interviewing, we usually want to have more reflections than questions, as well as more complex reflections than simple reflections in general. And so something that is done in the Mighty scoring is that they calculate, or as part of scoring it, one would calculate what percentage of reflections are complex, You would also calculate the ratio of reflections to questions, so how many reflections a clinician makes versus how many questions they ask. And so all of this really helps unpack some of not just the core skills of motivational interviewing, but how those skills and strategies are applied. And then it can give people really clear data on how they can improve, and that's really motivating for folks. So now we're going to practice, and we're going to practice just using the global scale of empathy. So we're going to play this example and listen to it, and as you're listening to it, I want you to be considering where on this empathy scale this clinician falls. And then after we're done listening, I'll invite everyone to put that numerical score, from 1 to 5 into the chat. So if I could have help in starting this recording, thank you.
So you're worried about how much you're drinking? Yeah. What are you worried about? Well, I guess I've heard some comments from my husband and some of my friends have noticed and said something. And once they said something, I really realized that probably not. So your friends and family members have convinced you to look at your drinking? I don't know if convinced me. They definitely said something about it. Good to be aware of something. So it sounds like other people see your drinking as a problem, but you really don't. Yeah, I guess. And I didn't realize, I didn't even think it was a problem. The only problem is what they say is that I'm drinking more than I usually do. What are they saying about your drinking? Just say that you think you've had more than you usually have. What's going on? You seem to be drinking more days than you usually do. What's going on? Why is that happening? They're really noticing a difference. Yeah. And what do you think of that? Well, I think they're noticing a difference maybe in amount, but I don't see how any problem with it is. It's not like I'm drinking more and I'm blacking out or something, or causing trouble with my family or having fights. Focusing on stuff and drinking a bit more. But you don't see any consequences resulting from it. Well, maybe it's a little bit harder to get up in the morning, a little bit more foggy-headed than usual. But nothing that would make you want to change anything. I don't know if want to change anything. I don't know. I'm still. I feel like I really enjoy drinking, and it helps me relax when I come home at night. Maybe it's because I've been a little bit more stressed at work, so I increase the amount and increase the days that I drink. And the only thing I've seen is people have noticed, taken me notice, and of course I don't want people to think I'm drinking too much when they're too much. Or, but I am really feeling a little bit foggy-headed and a little bit more tired and maybe a little bit more tired. So something's going on there. Yeah, there's a few things. Well, it sounds like some people are concerned about it. You have a few concerns, but you're not quite sure what you want to do about that. Yeah, I guess I'm wondering, just cutting down is fine. Cut down a little bit more to back where I was and drink maybe that fuzzy thing in the morning. That might be sufficient. Be fine. Cutting down. It doesn't work for everyone. What do you mean by that? Well, some people try and cut back on their drinking, but they still have problems. They still have negative consequences. So oftentimes clients come in here and they think that cutting back would be a reasonable alternative for them, but it really doesn't work. So you're saying that the only way to do this is for me to quit totally? Well, it's really up to you. I mean, you're the only one who can make that choice. But people that I've seen haven't been successful with that. Well, I kind of disagree with you there. I think that I could probably, when I was at the the level of drinking that I was just before this, I was fine. Didn't have problems. So what's the difference if I just cut back down to that level? Seems fine to me.
All right. Well, it's really, it's up to you. You're really going to be the one that makes that decision, and I can't tell you what to do. I just giving you some insight. But it sounds like, if you want to cut back, how do you think you would go about doing that?
Well, I guess because one of the things is that I wasn't aware that I was drinking much more until people pointed it out. So maybe I could just, I don't know, maybe I could just kind of keep track and maybe set myself some goals and some limits and see if that works.
That's a really good idea. How would you go about keeping track?
Okay, thanks everyone. So we stopped the recording there, just for the sake of time. But where would you score the clinician's level of empathy in the few minutes that you heard? All right, thanks, folks. So that clinician was at about a 3. So we saw some attempts to understand the client's perspective, but we did hear a lot of the client, also responding, no, I don't think that's it. I don't think that's the case. No, I wouldn't say that. No, I wouldn't, So a lot of the client having to work very hard to help the clinician understand what she's experiencing, how she's feeling, how she feels about her drinking, right? So that was actually a motivationally interviewing inconsistent example. And if you go to the University of New Mexico's website, their Center for Alcohol and Substance Abuse, they have several recordings and transcripts of MI inconsistent examples so that people can practice scoring examples that are inconsistent, because they got the feedback of, okay, you've given us all these examples of really well done motivational interviewing with high fidelity, but our clinicians aren't there yet. So how can we practice scoring some sessions that aren't highly adherent to motivational interviewing? So they have a whole set of resources there available for free. So now we're going to move on to the next example. And the next example is a video. So if the video plays, it's not like a big deal if you look at the actual video. It's just when we're using the Mighty, we only score based on the audio. So feel free to not look at it as well. And we're going to play about 5 minutes of it, just so you can get a good taste of it. And then we'll also ask you to put in the chat what number you, what level of empathy, what score you would give this clinician.
Okay, Gabriela, I'm turning it back over to you.
Thank you. So again, if folks can go ahead and review the empathy scale and then rate this clinician on this scale, what number would you assign her? Yeah, I'm seeing a lot of 4s and 5s. So this example is out of 5, so that she is picking up on things that he hasn't even really said yet, being able to read between the lines, being able to articulate and reflect what he's feeling, but hasn't really said yet, and we see him opening up more because of it. I wish I had the time to play the whole session for you. Unfortunately, we don't have that time together. And, of course, I want to give credit that the clinician in that video is Teresa Moyers, who is one of the giants of motivational interviewing. So she has a lot of recorded examples and is great to learn from. I'm hearing a little bit of an echo on my end. I wonder if anyone else is hearing that. All right. Thanks, everyone. So then I also wanted to highlight a program-level Fidelity tool using a top-down approach. And this is the Dual Disorder Capability in Addiction Treatment Toolkit. So it's both a Fidelity tool as well as a toolkit. And here you have just a map as of 2011, the different states that were using it. And this is very teeny tiny writing. I don't expect you to be able to really read this, but what I want to do is highlight some of the ways that it is set out. So it has, again, that anchored scale from 1 to 5, 1 being addiction-only services, and 5 being dual diagnosis enhanced, which is the highest level of integration of mental health services in substance use disorder treatment. And as you can see, there are descriptions for each point on the scale. And so there are some organizations and some states that will actually have, people who come in and can review a program using this scale and then provide strengths-based individualized feedback. Now, many organizations have also decided to take this toolkit and just use it themselves, and many times either have a person from a quality department or a director, go through the toolkit and, assign some of the different values, and then collaboratively with the team make a plan for how to increase responsiveness to people who have co-occurring conditions within their substance use disorder treatment services. As a director who went through this process and used this toolkit, it was exceptionally helpful. And so this is an example of that kind of program level piece that can help you see how you can increase fidelity to providing services for co-occurring conditions. That was our pause, so we're going to skip that. And now talking about fidelity from the bottom up. So here what we're doing is that a fidelity tool may not already exist, or if it exists, it may not really be make sense for our context potentially. So here we're going to specify the intervention components. What are the core elements? What are the pieces that we want to really ensure are happening as a part of making sure that this evidence-based intervention or the skill set is being used or delivered? And then once we specify those components, then we monitor whether the intervention is being implemented as specified. And again, the data can be used in supervision and training and for ongoing quality improvement. So here, clearly specifying the elements of the intervention is the first step. So if there is a manual or if there are guidelines for an evidence-based intervention, that can help you in identifying some of the core components of the intervention. So that can be a resource. Some things you may want to consider are specifying the dosage of the intervention. Is there a number and frequency of meetings, a length of sessions? Is there a minimum level of contact? You may want to consider specifying the nature of the interactions between the client and the practitioner. So is there a way that questions are asked, for example, open versus closed questions, or how we respond to questions? What potentially are we responding with, resources or skill building, or how do we respond to, someone who is voicing that inability to change, or that they don't feel like they need to change, or that they don't want to change, or they don't agree that they have a problem. Maybe they've been mandated, right? How do we respond to that? Do we respond to that with kind of just rolling with it? Do we respond to it with interpreting it? Do we respond to it with, so what are the different options if those are a core part of the intervention? We may want to specify the content of the intervention, like what topics are discussed and what kinds of things are learned, right? Are we trying to help people learn skills? Or is there more self-exploration, learning about self and redefining self? Or is there learning around interpersonal functioning, for example? We might want to specify the structure of an intervention. Is there a specific format for a session? Do sessions have to happen in certain places, like in the community or in an office setting? Are there certain roles in the team? So, for example, assertive community treatment teams are going to have very specific roles as part of the interdisciplinary team. And then what is the understanding of how we interact with other people, for example, with family members and significant social support? So some of the elements in Fidelity tools are going to include how we are monitoring those components and then the source of that information. And so here you see some different examples. And then I want to walk us through a way to develop a bottom-up Fidelity tool. So here's an example for an expert program, so screening, brief intervention, and referral to treatment program. So Josie works at a hospital in a brand new expert program where she receives referrals from social work and nursing staff to implement bedside screening, brief intervention, and referral to treatment to patients. The program components are screening patients for risky alcohol and substance use using a standardized screening tool, delivering brief interventions to those who screen positive, and then linking those who are screened at moderate to high risk using the standardized screening tool to needed treatment resources. So I want to hear from you all. Please enter in the chat. What might you include in a Fidelity tool? Thinking again of the different elements of the core components. What are the core components in this program that you might want to include in a Fidelity tool? Yeah, so the screening using a standardized screening tool. Absolutely. So We want to know if Josie is coming in and just kind of saying, hey, you want to go to treatment? Here's treatment, right? Because that would be missing some of the major components of ESPER. And then, yeah, absolutely. Were the brief interventions delivered to those who screened positive? Absolutely. Or did somebody get a positive screening and then it was a, good day and good luck? And absolutely, the number of referrals. Were those who were screened at moderate to high risk referred to needed treatment resources? Absolutely. And then even with those brief interventions, what are the specific brief interventions that are being delivered, right? What do those look like? What are we calling a brief intervention in this case? And are we using a screening tool that is culturally relevant and is culturally sensitive, has been found to be valid? Absolutely. What data sources might you use? How might you collect this information that you're trying to monitor? What data sources might you use to know whether standardized screening tools are being used that are appropriate? How might you know the clinical file? Yes, the medical record. Absolutely. Absolutely. And then you may also at some point want to shadow Josie, get a sense of how the brief intervention is being delivered. There's certainly a lot here that we can get from the medical record and a record review. And we might not really be able to coach Josie on delivering the brief interventions if we're not kind of seeing how it's being delivered. Yeah, potentially using an audio recording. Absolutely. Thanks so much, everyone. So now we're going to launch our second poll of how is Fidelity currently approached in your setting. From a top-down approach where you're using a tool that has already been standardized, has already been validated, from a bottom-up approach where you're defining what are the core components and then defining how you're going to monitor those and what the data sources are, both, neither, or I'm not sure. And we'll give folks just another 30 seconds to submit their answer. All right, and if we can go ahead and show the poll. Great. So we have a lot of folks that are using both approaches. And then with folks that are using top-down and bottom-up, if you wanted to be able to add another Fidelity piece, you don't have to necessarily, but if you wanted to be able to add one, it would be a lot easier because you already have pieces in place to be able to be collecting information and evaluating it. And folks who aren't sure or aren't using any kind of Fidelity tool yet, I'd love to hear in the future how you take this information back to your organizations and whether, which way you decide to start measuring Fidelity, if you do start measuring Fidelity. I'd love to hear. So now we're going to talk about methods and evidence-informed adaptation. So any adaptation has to be careful, has to be well-reasoned, or we can't assume that the intervention is going to even hope to have the effectiveness of the original. Now, ongoing evaluation and monitoring is important whether our intervention is implemented with high fidelity or with adaptation. It doesn't really, so we need to be able to measure the effects of what we're doing, whether or not we're adapting. So I want to hear from y'all. Why would we ever adapt an intervention? We've talked all this time about the importance of fidelity. Why would we ever adapt an intervention? Why even talk about adaptation? Something is better than nothing, ? Yeah, so it may be the case that, a lot of these interventions are tested and developed in very resource-rich settings and circumstances. And it may be that in a community-based setting, we just don't have those kinds of resources. We just don't have access to those kinds of resources. And so we may need to adapt an intervention in order to be able to offer it. At the same time, that's where the monitoring is so important, because our interventions do have the capacity to cause harm. And so we want to be sure that we are offering something that is helpful and definitely not harmful. Because every client may need something different, so we need to be flexible. Absolutely. Individualizing our approaches and our interventions are really important. There are no cookie cutter approaches, and, evidence-based practice is not about just, a cookie cutter approach by any means. Because adaptations can be effective. Absolutely. Outcomes can be positive with adaptation. Adaptation can improve outcomes. Absolutely. Yeah. And that, population may change, the cultural diversity may change in the groups that you're serving, and that there may need to be cultural adaptations. Absolutely. And here, Shantae wrote, to enhance the monitoring of the program and practices for quality services to a very diverse population. Absolutely. When we're talking about evidence-based practice as a verb and making adjustments based on the effects of the intervention, part of that could include adaptation. Absolutely. Thanks so much, everyone. So I'm going to kind of speed through this last part, so I make sure to leave time for questions. So there are so many reasons why we may need to adapt an intervention, including when people have been historically excluded from research samples. So populations that have been historically excluded include many different communities and experiences, including communities of color and survivors of intimate partner violence. And so we know that there are high rates of people experiencing current intimate partner violence, as well as intimate partner violence in their lifetime, in the past, that are accessing services in substance use disorder treatment, as well as mental health care. And that, when people experiencing intimate partner violence have been excluded from research samples, there's a whole host of people in our services that we may not have a whole lot of relevant research about what might be most safe and most effective for them. In the spring, I'll be delivering a session on culturally responsive treatment through FADA, and that session will talk specifically about culturally adapted treatment. So I'm not going to get too into cultural adaptations in our remaining time here, but know that in that spring session, I believe it'll be in March, I will be going into cultural adaptation in that session. So when thinking about survivors of intimate partner violence, here is an evidence-informed framework for enhancing any existing evidence-based practice that you use to enhance it to be more responsive to the needs of survivors. And when I say it's evidence-informed, that's because it was based on our systematic review of trauma-focused interventions for survivors. And so this included interventions both for mental health and substance use. So first, including psychoeducation about the causes and consequences of intimate partner violence and their traumatic effects. Second, awareness of mental health and substance use coercion and how intimate partner violence often attempts to sabotage recovery efforts and engagement in treatment. Third, attention to ongoing safety. So being able to safety plan with folks as well as connect folks to domestic violence services for more in-depth and ongoing safety planning. Fourth, cognitive and emotional coping skill development to address trauma-related symptoms and support people in their self-defined goals. And this is something that, based on what I've seen in the chat, what I've heard from folks, we're all using some kind of skill development or some kind of intervention that includes skill development. And so this piece should be especially easy to just be sure that we're adding in. And then finally, fifth, a focus on survivor strengths as well as cultural strengths on which they can draw. So both individual strengths as well as community and cultural strengths. So now, here is a framework for defining the elements of an intervention because, frankly, adaptation is the norm. And so this framework can help inform our adaptation as well as can help prepare us for using more bottom-up approaches to fidelity. So we're going to define what are the core elements of an intervention, what are the key characteristics of an intervention, and then what's the internal logic? And how do we use that knowledge in adaptation or in bottom-up fidelity construction? So the core elements are required. So we don't mess with these ones. They're required elements that embody the theory and internal logic of the intervention and are responsible for producing the main effects. So these essentially define the intervention and must be kept intact in order to produce the desired outcome. And sometimes there is even research that defines what are the core elements versus key characteristics versus internal logic. So for this, I'm going to use the example of Housing First, which is a highly evidenced housing model for people experiencing both mental health conditions and substance use disorders. So Housing First, the core elements are that housing is a basic human right, that there are no requirements that precede housing except for lack of housing. So really there are no readiness indicators. That within Housing First, there is rapid housing access, and there's a large focus on housing retention. So that's kind of, hence the name Housing First, right? Then there's fostering a sense of home, greater integration in the social and community ecosystems, that self-determination is honored, that harm reduction approaches are used, and that the approaches, excuse me, are individualized and person-driven services that promote recovery. So here are the core elements. Now, key characteristics are important, but not necessarily essential. So they're parts of an intervention that are recommended activities and delivery methods, but they may be able to be adapted in order to fit the practice context and the needs of the people in the program. So using again the example of Housing First, the key characteristics are a team approach to support services, a multidisciplinary team that's able to directly provide nursing and behavioral health services, housing that is integrated into the community, many times also known as scattered site housing, that they offer representative payee-ship services, also known as money management services for people who receive disability benefits, that there's a low participant to staff ratio, that there's weekly face-to-face meetings with staff, and that there is a separation between property staff, so staff that are responsible for things like rent collection, if there is a rent portion being paid, and who, are responsible for like leasing and enforcing the terms of the lease. But there's a separation between the property staff and the clinical staff. So these are aspects of Housing First that may be modifiable. That doesn't mean that if we modify them, that we should just assume that everything is going to be as effective as we've seen in the original and ongoing research, right? That we still have to be able to monitor and evaluate and adjust our program if we're not seeing those positive outcomes. And then the internal logic is the explanation of the relationships between the intervention activities, the behavioral determinants, and the intended outcomes of the intervention. So basically, why we think this works. And so the Housing First internal logic is that housing is the foundation of safety, health, and wellness, and that people are able to make meaningful progress in their recovery and well-being when they have independent housing with appropriate person-centered support. And so any adaptation that we make should not interfere or contradict the internal logic. And if it does, it is no longer that evidence-based intervention. We have changed it so much at that point that we cannot call it Housing First. So if you decide to adapt, know that adaptation is the norm. That most of us have a need to adapt many of these evidence-based interventions. So if we do adapt, modification should not compete with or contradict the core elements or the internal logic of the intervention. We want to seek data that can help us identify ways in which the intervention may need to be adapted or maybe has already been adapted. Has there already been a cultural adaptation of this evidence-based intervention, for example? For example, you might search for characteristics of an intervention with a particular cultural group or in a specific setting, like using if Housing First was developed with community-based housing, then looking for research about Housing First in congregate living situations and project-based housing. You may also use qualitative data that talks about people's experiences, and that metasyntheses that combine multiple sources of qualitative data can be especially helpful here to inform that adaptation. When we adapt, we want to document the circumstances that led to adaptation. Then we want to document the specific adaptation we made. So we don't want to go about it willy-nilly, right? We want to actually use some methods and then evaluate what are the results of that adaptation and compare that to the outcomes of those with full fidelity, so of the original research. And if it still isn't approximating the original research, then we have to really consider, we have to analyze that, we have to think about that, right? And the use of focus groups can be helpful here as well, always centering the voices of community and persons served. And we also want to share our data, at least locally. You know, you might not have the desire or need to kind of publish it per se, but to share it at least locally in your community with other providers, because for a couple of reasons. One, when we know we're gonna share data, we tend to be a lot more methodical in how we approach it. So that will improve our outcomes and evaluation overall. Second of all, if you're having the need for adaptation, it's very likely that others are also having this need for adaptation. And we need to be able to contribute to the practice wisdom in our community, and because your experience in adapting this intervention will be very likely able to help others in similar situations. And then ultimately, the common elements that many evidence-supported approaches share many common elements. So here, we may decide, you know what, to really look at what are the common elements, you know, that overlap between so many of these different interventions that have been found effective and that we're considering. And if we want to really focus on shoring up these common elements in our practice, we want to, of course, build on existing strengths of our program. What elements is the team, is the program, are we already practicing? What are we especially good at? And how can we leverage that for growth within our program? And so I don't have time. I'm almost at the end of time, so I don't have time to ask you this question, but this could be a really great question to talk about in your team meetings, both with frontline staff as well as in your senior leadership teams. And that many of the interventions that we use in substance use disorder treatment, as well as mental health and co-occurring conditions, as well as family-based services, have these common elements, right? The relationship. The relationship is the most evidence-based thing. Safety first, attention to safety, empathy, right? Outreach and engagement, motivational pieces, helping people connect with resources, all these different pieces, right? Supporting continuity of care, skill building, recovery oriented, having a long-term perspective, right? So a lot of these overlap over the most commonly used evidence-based interventions. And finally, always keeping in mind that when we used manualized interventions, the manual is not a substitute. The manual is not a substitute for our clinical skills, for our empathy, for our relational skills. They only work when combined with our ability to engage folks, our relational approaches, and of course, cultural humility. So with that, I recognize I'm at the end of time, so I want to open it up in case there are any burning questions. And then as folks put those in the chat, I'm also going to flip through to some additional resources. On our website, we have a whole section that is dedicated to resources for mental health and substance use treatment and recovery support providers. We have our online repository of IPV-specific trauma interventions. We have a guide that I wrote on supporting survivors who use substances. We have a whole lot of resources on substance use coercion, which is one of the things I had mentioned, and then also a coercion toolkit that can be used in both mental health and substance use and primary care settings, and so much more. Our references and then my contact information, please feel free to reach out. And I want to say thank you, of course. Thank you so much for being here today. Thank you so much to FADA and the Department of Family services for, help, for support with all of this. Thank you for having me. I'm so happy to share this information. And I don't see any questions coming through, so I will turn it over to Karina. Thanks so much, everyone.
Thank you, Gabriela. And can you hear me? Can you hear me okay?
I can hear you.
Okay. Just wanted to make sure. Just have a couple of housekeeping things to run through, but I did want to thank you again for presenting. We always enjoy it, and you always share so much knowledge that you have with us. It's very helpful. So if you guys can just hang on a minute, I just wanted to go through a couple housekeeping things. When we conclude today's webinar, your browser will take you to an evaluation on our website. And if you want to receive CE credits or a statement of credit, please complete the evaluation. We love your feedback. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number for the first time that you register. So after you register and sign in, you're going to be directed to the evaluation. You may consider using the same email address when you register for our webinars through our WebEx link so that we can connect your attendance with your profile. You'll get a second opportunity to complete the evaluation through an email that you should receive once we conclude the webinar. It will be from sender messenger at WebEx. And that evaluation, again, is due by midnight, Friday, December the 11th. We do not email statements of credit. Instead, after we verify your attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Once you complete the evaluation, you'll get a message just thanking you for submitting your evaluation. Just wanted to remind everyone that posting your credits can take up to 30 days after the evaluation closes. The PDF is available on our website, and the recording will be available within 30 days in our training library. To access your statement of credit, you would just sign in and go to your profile under Manage Profile, Content and Features, and under Professional Development. And again, that takes up to 30 days after the evaluation closes on December 11th. And with that being said, I just want to thank everybody for attending and participating in today's webinar. We want to thank you, Gabriela, and we'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation. Thank you.